All right, the next chapter is on controlled ventilation. When you're looking at ventilation, there's basically three elements that really control the respiratory control. Yes? What's that? Did we finished chapter 7, right? Yeah, that's what I thought. So what you're looking at is you have sensors that are gathering information that are basically going to stimulate you to breathe. These sensors are located in different parts of the body. There's even sensors in the muscles. There's sensors in the heart. There's sensors in the lungs. These are kinds of constant feedback mechanisms that are sort of helping the brain determine how you should breathe or not. Then you have the central controllers, which is in the brain. This is usually considered inside the brainstem. So as a consequence, even though you may lose cortical function, most people continue to breathe. Okay, even so, the person can't be awake anymore, is completely unconscious. The person continues to breathe. So it's the central controllers are actually the most difficult to knock out, and it's located in the medulla oblongata. Is the primary pacemaker for respiration. The effectors, which is what the central central controller actually controls, are of course muscles, and the muscle of most importance when you talk about ventilation, of course, is the diaphragm. What you're basically are going to do is your sensors are going to sense changes in pH, really. We call it senses CO2 changes, but in reality what it's sensing is changes in pH in the central nervous system. Okay? So here are your different kinds of things that are information that's afferent. You have your psychogenic, which is a psychological component. People can actually increase the respiratory rate just under stress or imagination of stress. You've all gone to scary movies, and if you watch your respiratory rate, it definitely increases. And although nothing is really happening that's endangering you, it's all psychological in the sense that it's the movie that's causing you to think that way. But it causes physiologic changes in you as well. Okay? There's, of course, biochemical things that are in your bloodstream that definitely will alter your pH. CO2 and hypoxemia can also induce the person to breathe. And there's vascular, which are baro and mechanical receptors located throughout the body, which sends sensory information back to the medulla, which is the respiratory drive center. This is the central control mechanism. And then you also have mechanical spindles, such as muscle spindles and irritants and stretch fibers that all are important in helping breathe. Okay? Eventually, from the respiratory drive center, which is the central modulating area, you send out control mechanisms to control the diaphragm and the other muscles that are responsible for breathing, including the accessory muscles, the internal and external thoracic muscles. So you have a lot of different muscles that are very important to control ventilation. So if you break it down, you can actually look at it most of the time as mechanical receptors, which are mechanical devices that actually sense changes in pressure or changes in increased workload, and chemoreceptors, which of course sense things like CO2, pH, and O2 changes. Ultimately, they come down to affect the respiratory neurons, which causes the nerves to fire. So that means that you must have an intact nervous system. This is all a reflex action. Okay? So when you're looking at somebody's respiratory drive, it's really telling you about the person's ability to have an intact nervous system. If you see somebody all of a sudden stop breathing and they appear to be awake, and then they still don't continue to breathe, that's a fairly serious condition at that point, because that person should be breathing. And what it could be is you could have phrenic nerve injury. Okay? You could have an injury with the diaphragm. You could have an ascending paralysis. You could have a spinal cord injury, okay, where the spinal cord has basically been knocked out, but the person is still mentating. The cortex is still functional. Example, that would be somewhere like a spinal anesthetic that's gone high, or an epidural that's gone high on you. That's a perfect example of somebody who has everything sort of intact, but the actual neurons that are sending the information out just don't connect. So when you're looking at respiratory drive, you need to look at the whole arc and imagine in your mind, where is it failing? Okay? If I give you high-dose narcotic, is that going to affect the neurons? Not at all. Okay? But instead, if you give high-dose narcotics, it's going to knock out the medullary respiratory respiratory drive center. That's how it really works. It suppresses you by making you not want to breathe at the central area. Okay? Now, what's interesting is that even though you can suppress people's respiration selectively by certain agents, the person may still be awake, and you may not know it. Just think about that. Have you ever seen a heroin addict come in, or somebody on high doses of narcotic ever come into the emergency room? And you talk to them and you tell them, hey, breathe, and they breathe. But as soon as you stop telling them to breathe, they stop breathing. Okay, those people are actually awake. Okay? The reason that they're responding to you is because they're hearing you. But once they don't hear anybody telling them to breathe, they feel, I don't really care if I breathe or not. It's okay if I die. I'm too comfortable. And they stop breathing on you. Okay? So understanding how all this stuff works is pretty critical. Okay? And of course, you can give agents that can paralyze muscles, which is something we do often. That doesn't mean that the person is not awake again. It does mean that you knocked out the muscles themselves. So let's look at the individual sensors. The central sensors, chemoreceptors, are located in the ventral surface of the medulla. Remember, that's a portion of the brainstem. That's the lowest portion of the brainstem. It's sensitive to CO2 changes, but not so much to PaO2 in the blood. So really, the sensors that are inside the brainstem are really sensing changes in CO2, but mostly really they're sensing changes in pH. Really, that's really what the sensor is sensing. And we know that to be the case because I've seen studies done where they actually put a catheter in the medulla oblongata, and through that catheter they deliver CO2. Okay? When they deliver CO2, they see the respiratory rate go up. So you think, well, that's what's causing the drive mechanism, right? Okay, well, then they take the solution that they mix. Instead of giving CO2, they give acid, hydrogen ions. Okay? And, of course, the respiratory rate now increases, but at what cost? The CO2 levels become depleted. The person becomes to hyperventilate, and the brain does not care. So which is the primary mechanism to drive respiratory drive? It's pH changes in hydrogen ion concentration. Okay? Now, that's really nice to know, okay? But in reality, clinically, what's relevant to you is that normally, 99.9% of the time, the brain is not using hydrogen ions. They're sensing hydrogen ion changes that are occurring into the CSF. But what's occurring is that CO2 transfers into the brain very easily because it's a very diffusible gas. Remember? CO2 is 20 times more diffusible than oxygen. So if you become hypercarbic in your peripheral system, then when the blood comes back with higher levels of CO2, it's going to cross into the blood-brain barrier very easily and then alter the pH, which causes you to drive and breathe faster. Okay, so it is, to a certain extent, still CO2 sensitive. Okay, and that's what you want to sort of think about. It responds to the changes in pH, and I just talked to you about. The CSF pH is the most important. It's what the brain's trying to do is maintaining a very tight control of acid base in the brain. There's also peripheral chemoreceptors. These are located in the carotid and the aortic bodies. If you look at the aortic body receptors, they don't respond to PO2 or pH changes at all, but instead they tend to only sense CO2. So it's really not, that one's really not a pH sensor. Okay? So it's carried by the vagal nerve, which is cranial nerve number 10. If you go up to the neck, that is actually carried by the glossopharyngeal nerve, which is cranial nerve number 9. Okay? And that is by far the most sensitive peripheral chemoreceptor to changes in CO2 and hydrogen ion changes. Okay? It does also respond to PaO2 changes if you're awake. Okay, if you're awake. In other words, if you're not sedated at all, then if your bloodstream develops hypoxemia, the respiratory drive tends to increase. But under anesthesia, guess what happens? That system is knocked out. It is completely ineffectual most of the time. Okay, so really what's going to cause you to drive to breathe is to increase the CO2 levels in an individual. Now that's kind of a good thing because some people would be kind of stupid and say, well, I'll just make the person hypoxic and they'll breathe. No, that's never a treatment plan for us. Okay? You don't want to make anybody hypoxemic ever if you can avoid it. Okay? It's not really appropriate. It's not safe for the patient. You can have complete loss of hypoxic ventilatory drive in patients that have bilateral carotid endarterectomies, and that can lead to some rather interesting and rather challenging postoperative course in these people. What will happen in these individuals if they are chronic COPDers and their CO2 sensor has gone out, okay, when they wake up and they should be back to being O2 sensitive to breathe, now they don't breathe. They'll sit there and look at you, and it's really irritating. You got to tell them breathe. And it'll take you sometimes 8 to 12 hours of telling them to breathe, but eventually the sensors start being activated again. And that can be kind of a bore really quick if you're in a recovery room nurse. So that's why we don't like doing bilateral carotid endarterectomies. You know, we usually don't do them at the same time. We do one at a time, and then we do the other side. When you get into trouble is when you do the second one. The first one is not such a big deal because the sensor is still intact on this side, but once you knock it out on both sides, then you got an issue at times. They're really rapidly responding, but not as strong as the central chemoreceptors, okay? Which means that, of course, it makes sense. I mean, if the brain's seeing that pH changes are not something that it desires, it's going to make a much more dramatic change in breathing pattern than in the peripheral receptors are. This is the important sensors you have in the aortic body. This is the vagus nerve, okay, coming back to the brainstem in the medullary area. And then you also have the glossopharyngeal, which is also coming back afferently and giving information back to the medulla oblongata. Remember, there's always four cranial nerves in each portion of the brainstem. Okay, so the medulla oblongata gets the last 4. So it kind of makes sense that it's got 9, 10, 11, and 12. And the main ones that are afferent are 9 and 10. What you're looking at here is a way of responsiveness to CO2. And what will happen as CO2 increases is that minute ventilation tends to increase dramatically, okay, to try to maintain the CO2 to be stable. Okay? So if you look at PO2, which is, where is it at? It's not on, yeah, it's this one, okay? It's not really that sensitive until you get below 60. That's when ventilation starts taking off on you. Before that, pretty much as you increase CO2, ventilation continues to increase dramatically. Okay, now you have inside the additional receptors that help you breathe are feedback mechanisms that are located in the lung. Okay, we have one thing called a pulmonary stretch receptor, which is called the Herring-Brewer reflex. Okay, most books will tell you that the Herring-Brewer reflexes only exist in dogs, okay, and doesn't really exist in humans. I tend to disagree with that statement. Okay, the reason I've been disagreeing with that statement for the last few years is because I actually induce a kind of reflex to get people to breathe faster, okay, which is kind of something you're not going to read in the books. What I've been sort of playing with for the last few years is trying to get people to spontaneously breathe faster at the end of the case. And one of the things that I find frustrating is that if you let the CO2 build up, then eventually they'll breathe for you. But that usually takes too long, and patients begin to desaturate. So what I've been playing with the last few years is to give these people CPAP, which is just continuous positive airway pressure. And people will say, well, if you give somebody CPAP, you're going to cause hemodynamic instability. And the answer is you don't, not if you do use 10 of CPAP. And if you're at 20 or 30, yeah, you shouldn't be there. But at 10 of CPAP, the heart's going to be just fine. Okay, they're not going to be really affected by it. The nice thing about being at 10 of CPAP is also that the lung doesn't deflate on you. It doesn't get alactatic, and you don't desaturate. And what I've also been noticing over the last few years is that if we were to take the same patient and sort of just play with them and just let the CO2 build up, we would notice that by the time we got them to breathe, it would be around 48 to 52 on the CO2 before they would really start to breathe. But by giving that person CPAP, where I've noticed is that the CO2 actually is around 46 to 44, which is about 4 less than you should anticipate. So then what is causing the initiation of breathing? It's not CO2 then, it's something else. And what we've noticed is that if we bump the CPAP just up a little bit to like the 12, clinically you end up seeing that the person starts to hiccup, which is nothing you don't really want to see because the person ends up then bucking a little bit, which you don't really want to do. But at 10, it's going to be a perfect place. That's where we sort of now teach people, at least where I teach people, okay, you want them breathing faster, put them on 10 CPAP and wait about 2.5, 3 minutes and they'll start breathing. And it's a reflex, I think, the Herring-Brewer reflex. Once the lung inflates to a certain point, it wants to exhale. The diaphragm doesn't want to sit there at a full loaded capacity. It wants to unload a little bit. So it begins to try to initiate the breathing mechanism. So it's kind of a cool thing to do. You can play with that a little bit. It's not going to cause anybody any harm or anything like that. Just once they start breathing, then you open up the pop-off and let them go. Okay? And it's a really quick way of getting people to spontaneously breathe at the end of the case. We just did that on a case right before I came here, and we were extubated within 42 seconds of the surgeon putting the last stitch in. It's pretty cool. And we got him breathing about 2.5 minutes before the surgeon was done. Okay? So, and we use this trick. It's kind of a nifty little thing. There's also receptors that definitely are real, which are irritant receptors, which is something you don't ever want to activate, by the way. Irritant receptors are nasty. They will induce bronchospasm. They will induce pulmonary hypertension. They will induce the person to buck and cough. So you really don't want to activate bronchoreceptors like that. The typical broncho irritant receptors that you have are found in the carina and in the larynx. Okay? The larynx is, of course, trying to protect itself from food, trying to get past it. And then if food does get past you, okay, and it does get into the larynx, it can go down to the carina, and then it'll induce a very intense irritant response, where the person will continue to cough nonstop. Let me give you a little story. This happened on Friday when somebody asked me about this, and a little detective work figured out what it was. So I wanted to get you on this. It's the same thing with this kind of response. We had a patient who came in, and they told us that the last anesthetic, that the anesthesia had caused them to have severe coughing bouts, and they did not do well. And I said, well, what did you have done? And he said, well, I went to a urology's place, and they did a cysto on me, and after the surgery, I was doing okay, but then I went to lunch, and as soon as I went to lunch, and I started coughing massively. What happened to this guy? That's right, he aspirated. Now the question is, why would he aspirate? Here's a guy that was apparently seen to be talking appropriately. He went out from the place where he was at, and they told him, go ahead and eat, you're fine. And as soon as he sat down and ate something, he apparently aspirated. Any ideas? What's that? Here's why. They put an LMA in the guy. Okay, and that doesn't sound like, well, LMA, it's not going to cause any problems, right? LMA, when you put it in the back of somebody's throat, it shouldn't cause any problems at all. The problem was that they put in lidocaine in the back of the mask. Okay? And when they inserted it into the esophagus, where it was sitting, now the lidocaine goes behind and knocks out the recurrent laryngeal nerves. Okay, so even though the person appears to be okay, they're a little bit hoarse, but they really are, they don't have an intact airway or laryngeal reflex. So this guy, of course, aspirated. Okay? Now, the reason he didn't aspirate massively and didn't do well was because he had what's still intact. He had the carinal reflex still intact. So as soon as a little bit of food got in the carina, he started coughing up massively to try to get rid of all the stuff that went down in his lungs, which he eventually did, and he ended up not getting the pneumonia and did okay. So when we did him, you know, the guy was uneventful. Not a big deal. But at least he got told what really happened to him. There's other kinds of receptors. They're called J receptors. These are located more deeply. These are chemical stimulated, which is most of the time you should not be exposed to it. This is some situations where if you're actively breathing in some kind of poison, then the person will stimulate via the vagus nerve, causes rapid shallow breathing, okay, and causes dyspnea. What the lungs are trying to do is just trying to get you to breathe not deeply into your alveoli, but just move the air in the dead space to sort of make you aware, hey, this stuff is not good that I'm getting down here. And then you'll have also bronchial C fibers. These are, again, stimulated by chemicals that are located in the bronchioles, and they also cause same kind of action, rapid shallow breathing, bronchoconstriction, and mucus secretion. These are irritants. These are things that you don't really want to activate. This is not good stuff to activate. Okay? Now, I've personally seen these things get activated, and I've seen where you actually grab the bag and you think you're ventilating a brick. Okay? The bronchioles are just like constrict down, and you can't do anything. Okay? You can't ventilate. You don't even get CO2 back. And you're wondering, am I in the right place? Am I in the esophagus? But the esophagus doesn't do that. The esophagus doesn't constrict down on you all of a sudden, and all of a sudden you lose your CO2. It's in the bronchioles that's causing this. So how do you terminate the action of something like this? What's that? Paralyzing it would not work. It's smooth muscle. You need, what is it? What's activating the reflex? It's a sensor. So how do you suppress a sensor? If I cut you in the hand right now, what it would feel like? It would hurt, right? But what happens if I do something else to prevent that from hurting? What would I use? I would use lidocaine, right? Local anesthetic, okay? So that's a sensor. The sensor is out here, but the sensor is inside here too. So we use an LTA. Shoot down the LTA down into the bronchioles. It terminates the sensor, and then the bronchioles reopen. It's a really nifty, very quick way to reverse your effects, okay? And you'll make the mistake one time of putting a tube in deep. Some idiot will tell you, it's okay, just stuff the endotracheal tube in, and then you pull it back. Don't do that. You're asking for it. On dead people, it's fine, because they don't have any sensors when they're dead. So when the paramedics are taught that, it doesn't really matter, because the guy's already dead. So maybe you'll stimulate them and cause the heart to maybe jump a little bit. That might be not such a bad thing. But in most people, when you're awake and you hit the carina, you cause really nasty effects that you really don't want to be there when that happens. Okay? So avoid that. There's also other sensors that people forget about, like in the nose. And I've seen this happen as well. When you put a nasal trumpet in somebody who's an asthmatic, all of a sudden you go into bronchospasm, and they start wheezing. And you're going like, what the hell's going on? Oh, it's an obstruction. No, it's not obstruction. You just activated the nasal reflex that caused bronchoconstriction. So you have to take your nasal trumpet out, and everything gets better all of a sudden. So be careful with asthmatics. They can trick you. The ones that really can be a problem is the asthmatics with nasal polyps. They're really prone to have this kind of reflex arc activity. There's also receptors that are inside your joints and muscles, which kind of makes sense. If you're going to increase your workload on your muscles, what would you want to do? You're going to increase your cardiac output, but that's going to also increase your ventilation. So you should expect and muscle activity like that to increase your respiratory rate. There's arteriobaroreceptors, and there's also pain and temperature. And depending on where the pain is at, it's a very good indicator of, I watch respiratory rate all the time to know if my patient's comfortable or not. The patients are intubated. Are they going to be able to tell you if they're comfortable or not? They can't even speak, and they can't close the vocal cords. Okay, so they're going to be looking at that, and they're going to wake them up. Now, how do you actually gauge how well your narcotic is based on respiratory drive. Okay, if I give enough narcotic, I can suppress the respiratory drive to 0. That's a little bit too comfortable. We don't want that. Okay. On the other hand, if we don't give enough narcotic and the person's really in pain, the person's breathing 35 to 40 times a minute. And when you pull the endotracheal tube out, you'll definitely hear it, but they're not comfortable. Okay? So you want to sort of be in a happy place. The happy place for me is about 12 to 16 in adults. In children, it's 16 to 20. Okay? So I add my narcotics, titrating them to effect to suppress the respiratory drive to the point that they are breathing comfortably. And when we pull the breathing tube out, the guy looks at us like, are you in pain? No. That's the trick of the job. If you can be an artist by extubating people when they're awake and not having pain, you have now hit the artistry of this job. And now you actually have gone to another level. And your patients will definitely be very appreciative of being able to do that. Okay? Other people believe in the rescue technique, which I'm not a fan of. Okay? The rescue technique is where you pull the tube out and you watch the person screaming all over the recovery room. Okay? And they know that at least all the recovery room nurses know you're coming. Okay? And they have the morphine out, waiting for you. They're the firemen. They're going to put out the fire. So they hit the narcotics, and right as soon as you walk through the door, and everybody's like, "Oh, you're so great." No, you don't have a clue what the hell you're doing. Okay, that's called the rescue technique. I'm not a real fan of that, so you won't see my patients coming out like that. At least not when I'm watching over you guys. Some other people will definitely do other things to you, though, so you'll get to enjoy that. The central controllers are, of course, in the brainstem. I am not going to make you a neuroscientist, okay? I don't expect you to know all the pathways and how the central, I want you to just know that the brainstem is where the stuff is at, okay? Because I could spend about a year just talking about how this thing works, okay? It's that complicated. We don't completely understand everything of it, but we do know that there is a primary respiratory autonomic process that's responsible for ventilation. Now, you can argue about how deep your breath is going to be and how that acts and what portion of the brainstem activates that. There's another part called an anoustic area will breath hold you. There'll be another area that causes you to yawn, okay? Yawning is usually the sign of death, though, okay? It means that you've given so much diprivan at that point that the person at that point is going to be apneic. And you better have had oxygen on them on board on that time because they're going to desaturate like a stone, okay? And what it means really is that you've given them so much diprivan that you've knocked out the medulla oblongata. And you've gone down to as low as you can go to the spinal cord as you can go. If you look at the respiratory centers, again, please don't memorize this. This is just to show you how complicated it is. Like I said, you can call it the medullary respiratory center. You can call it the anoustic area, the pneumotactic area. Please don't memorize it. I think it's all way over the top. Okay, I know some of the guys that I used to work with. We would just basically nail you on this all day long and think this was a great system to try to make you look small. In the end process, I kept asking, what does this mean clinically at all? And the answer was nothing. Not really. So because of that, I'm not going to hit you on this. Instead, I want you to understand is that your brainstem is the area that regulates breathing, and that certain agents can suppress it. Okay, and that's what we need to sort of know. Okay, again, more detail to show you all this stuff that's going on. I used to memorize all this stuff, and I thought, great, kind of cool, but Okay, this is where you want what you do. Okay. Overall, the brainstem is the main area that is controlling your breathing, but you can overcome it. The cortex can actually overcome your breathing. If I tell my brainstem, hey, look, breath hold. I'm not breathing because I purposely tell it not to breathe. The brainstem is going to start screaming at me saying, hey, you need to breathe. Okay, but if I want to breathe to the point that I'm unconscious, you can do it. Okay, I don't recommend it. The good thing is after you go unconscious, then the rest of the brain, which is said, hey, the cortex has gone nuts, we'll take over for them. Okay, and start breathing again for you. The major output of the central controllers, the main efferents, of course, are going to go out the phrenic nerves. But where are the phrenic nerves located at? The phrenic nerve is not a cranial nerve, right? Phrenic nerve is a spinal cord nerve. It starts at C3, C4, C5, mostly C4, C5, okay? So your brainstem is actually connected directly to that area, okay, via axons to tell it to phrenic nerves to fire and to breathe. The effectors that you're going to have are going to mostly you talk about is of course the diaphragm, which is the primary muscle of inspiration. But the other muscles that are important for inspiration are things like the sternocleidomastoid muscle, the scalenes, the inspiratory intercostals, and then you have your expiratory intercostals as well, which are the deeper structures that's responsible for active exhalation. But under most circumstances, you're looking at mostly the certain set of muscles that are responsible for breathing. And it develops what's called an integrated response, and that integrated response is a response to CO2, and then the second is the peripheral chemoreceptors. By far the most important thing to control breathing patterns is rapid changes in CO2. Okay? And your brain is constantly sort of figuring out this CO2 change, but it's the sensors in the brainstem that are, of course, pH sensitive that are being changed by the CO2. The most important is the central chemoreceptor, which is responsible to CSF concentrations, hydrogen ion, which I told you about before, because if you give enough hydrogen ion to the brainstem, it'll hyperventilate to the point of having zero CO2 in the bloodstream. I've seen that was a very elegant study done, so it shows you that the main one that really is most important to the brain is the pH. The second is a peripheral chemoreceptor, which responds to changes in pH and CO2. The response tends to be faster before the onset affects the brain. So, and the response is magnified by PaO2 is lowered on a normal individual that's awake. The CO2 is a respiratory driver. It's a brain sensitive to changes in pH. CO2 is a volatile acid member, converts into carbonic acid, H2CO3, and then it converts from that into bicarbonate and hydrogen ions, and then the hydrogen ions is what the brain senses. The brain sensor can be enhanced or suppressed by things like, it'll be enhanced by additional acids in the brain stem, so metabolic acidosis will make you much more sensitive to CO2 changes. A low PaO2, less than 60, usually also will hypersensitize the receptors, and the last one's elevated temperature. As for things that will suppress it, are things like metabolic alkalosis. So if somebody's alkalotic and then they start not ventilating CO2, there's a little bit of a buffering capacity because of that, and the consequence, the hydrogen ion doesn't really activate the person to breathe faster. You can actually, of course, give central nervous system depressant effects. Things like narcotics will do this. Even all the induction agents, if you give enough of them, you will stop the person from breathing. Naturally cold will also induce a decrease in respiratory drive over time. And then, of course, narcotics, which we talked about. Now, the main mechanism of response is ultimately has to do with minute ventilation. The brain is looking at overall at minute ventilation. It does not care if it has to do it one way or the other. It tries to be efficient, which it means that it's going to be dependent on the diaphragm. If the diaphragm can efficiently do its job, then it's going to do it mostly by by tidal volume. Okay? If the tidal volume, in other words, the diaphragm starts losing its function, what's the brain going to tell the system to do? It increases respiratory rate. But ultimately, it's trying to maintain minute ventilation. Okay, minute ventilation is what maintains usually your CO2 levels. That's why it's so important to understand that concept. Minute ventilation is not really important for oxygenation, but it's really responsible for CO2 elimination and maintenance. Okay, and that's really a very, very critical point. Okay, I can't explain that enough to you. The book doesn't really say that enough, and I need you to understand that that's really important. Okay? Now, when we give people volatile agents, okay, volatile anesthetics, what's going to happen to muscle function? It becomes paralyzed. Okay, so what will the person lose? It loses tidal volume. And so what does the person immediately react by doing that? It increases respiratory rate. So when people tell you, well, you know, that when you give a volatile anesthetic, the respiratory rate goes up and tidal volumes go down, it's the way the brain is being affected by the volatile anesthetic. That's bogus. I can give you volatile anesthetic directly into your brain of an animal, and the respiratory rate will not change or the tidal volume will not change, period. So it's not suppression of the brainstem that's causing it. It's the actual suppression of the muscle. Now, what is another agent that transfers into the brain really easily because it's really diffusible and has a blood gas partition coefficient of 0.46? Nitrous oxide. Okay? Nitrous oxide, which penetrates into the blood-brain barrier just fine, which would you would expect to suppress the brainstem, does not. Because what does nitrous not do? It doesn't affect the muscle. It doesn't weaken the muscle. So the person will actually maintain their minute ventilation by giving a bigger tidal volume when you're on nitrous oxide. Okay? If I give you the same level of MAC with furane or with furane with nitrous, the one that does better supporting ventilation is the one you would mix with nitrous oxide because that doesn't affect the muscles as much. Okay? If you go pure volatile, then you're going to cause more weakness in the muscle, which then is going to cause your tidal volumes to fall and respiratory rate to rise. Okay? All right? Does that make sense? Now, so pretty much the brain doesn't really understand that. All they care is about is CO2. If for some reason my diaphragm is really working well, okay, and my respiratory rate is dropping off, what do you think the body will react to it? It'll take a big deep breath, which is what narcotics do. Narcotics suppress you at the brainstem by slowing down your breathing, but the diaphragm is not affected by narcotics. It's not a muscle paralyzer of any sort at all. So what the diaphragm will try to do in that situation is it'll deeper breathe. it'll take bigger tidal volumes, which is kind of cool if you think about it. So we've got one agent that's going to give you bigger tidal volumes and slower respiratory rate. And the other ones, when we use volatiles, we're going to give you smaller tidal volumes but faster respiratory rate. Well, we can play them against each other, and that's what we do in the operating room. Okay? If we have somebody that's getting a lot of volatiles, we can reduce the volatiles by giving them a little narcotic, still make sure that they're amnestic, but they now are able to breathe better with less volatile. Okay, and they breathe deeper. It's kind of a nice process. Now, of course, anytime you're looking at any form of narcotic use, once you start giving to people, yes, they breathe deeper, but their respiratory rate drops off too much. So what do you end up happening with minute ventilation? Does minute ventilation go up or down? It goes down. So what happens to everybody's CO2 that's on narcotic? It goes up. And that's, you're going to have to pay that price. That's a Pied Piper. You're going to have to pay the price for the Pied Piper. Okay? If you plan to use narcotics, everybody's going to be hypercarbic, no matter what. Every patient that you take care of in the recovery room, that you've given them narcotics, has an elevated CO2 of 45 to 52, in that range. There is no way to get around it. Okay? At least we don't. At least right now we don't. Okay? But at least to keep you comfortable, you're going to have to pay that price. Now, the ventilatory response to hypercapnia does have genetic variables in these individuals. Okay? But most of the time it's linear. Okay? So in other words, if CO2 goes up, minute ventilation tends to increase, is what they're trying to show you here in this example. Okay? And what normally will also happen is your alveolar ventilation will tend to try to increase as well. And so people's tidal volumes tend to go up at times, depending on the situation you're in, or respiratory rate. So this is, I think, a very important graph. This is what I use clinically in the operating room to sort of decide what I'm doing. Okay? When we give people more and more anesthesia, let's say this is a normal person here. Okay? So if you drop it down here, their CO2 is around 40. Okay? And their minute ventilation in this person is awake. Okay? That's why they've got this value around 6 liters per minute. Okay? That's for a person who's awake metabolic rate like you guys are. I know you're tired, it's been a long day, okay? But most of you are breathing around 6 liters per minute right now. If I were to put you in your own beds and you feel very comfortable and going to sleep, your minute ventilation would drop down to around 3 liters per minute, because your basal metabolic rate drops off tremendously when you go to sleep. Okay? It's what gives us rest. Okay? It allows for not consuming calories. That's why bears hibernate. Okay? And they're dropping down their workload. Okay? Now, under normal sleep, okay, our minute ventilation drops off. Well, under anesthesia, guess what happens to minute ventilation as well? It's not needed as much. So we're dropping down. Okay? So our CO2 is going to stay at 40. That's pretty much where you're going to be. As soon as you put somebody to sleep, as soon as you start dropping the minute ventilation, then CO2 begins to rise. If I give that person a lot of narcotics, then the CO2 will be up in here, 55 region, before the person is able to breathe at the same minute ventilation. If I give you even more narcotic, the CO2 will rise, okay, and the minute ventilation may rise or may not. Okay, in other words, most of the time, people are not going to increase their minute ventilation most of the time as you give them more and more narcotics. You can suppress them to the point that they will stop breathing. So minute ventilation, to maintain that level, becomes a problem. Okay? And when you put people under deep anesthesia, okay, under volatile, you'll notice that it will take more, the CO2 will have to climb higher and higher before the person will even be responsive. You can actually give so much anesthesia to somebody that they won't breathe at all. You can be up in the 80s, 100, and the person never even breathes. Okay? But that's really way, way too deep. Okay? And it depends on the depth, of course. Okay? Now, the response to the oxygen is located in the peripheral chemoreceptors. They're negligible during normoxic conditions, and they're really kind of important at high altitudes or long-term hypoxemic patients with chronic lung disease. And they become like bad COPDers. Okay? But if you look at anesthesia and oxygen responsiveness, it's a waste of time. You don't expect somebody to be oxygen responsive. By the time they're oxygen responsive, they're not only desaturated, they're now in the 60 sats, but they're now also becoming hypercarbic, which is not a good place to be. This is what the graphic representation, this is what the books all show you, but this is for people who are awake, okay? It shows you that around 60 PaO2, all of a sudden the CO2 response curve and the alveolar ventilation rapidly increases. Yes, that's true, but that's for the person who is awake, not somebody who has any kind of neurological damage, or it's not anybody who is basically under heavy anesthesia or any kind of narcotic. So what we're looking at is we're responsive to pHs. Okay? Decreasing pH tends to stimulate ventilation because what you think about is CO2 plus water forms carbonic acid, which is H2O3, which then forms hydrogen ion plus bicarbon. The hydrogen ion is what the brain senses. So elevated students in CO2 will push that, chemical reaction forward. The chief sign with pH changes are going to be sensitive in peripheral chemoreceptors, and the second one's the central ones. And what they're trying to show you again is the hydrogen ion changes. The peripheral will fire to increase minute ventilation. Of course, the brain, once it gets the CSF changes, it will also cause an increase in receptor activation and then cause an increase in minute ventilation. The end-up cause is to drop CO2 by eliminating it by more effective ventilation, which then raises your pH back up, which then sort of shuts down this mechanism. So, and that's what your brain is constantly doing. It's a constant seesaw effect to maintain your breathing pattern. What should they say that? Okay, so now let's look at some abnormal patterns of breathing. You can have causes of irregular breathing from like low cardiac output states. Usually if you're down to that point where the person's now breathing erratically, that means you're not perfusing the brain. Usually it's the tip-off is the person's turning blue on you, and it's not from blue from their hypoxemia, it's because they're not perfusing. Okay? I've seen that enough times in my life, and people are sort of like, oh, it's the person's hypoxemic. No, how about no perfusion? So perfusion can be an issue. Okay? Central nervous system diseases like sleep apnea can also cause abnormal sleep patterns. Metabolic derangements from metabolic alkalosis to acidosis can all cause forms of sleep pattern breathing pattern changes. And if you have a child that's prematurely born, sometimes these sensors are not, and as well as the central activating centers are not really matured properly, and as a consequence, the person won't breathe. You have to be really, really careful with pediatrics cases. You have to ask if the kid is premature. Okay? If you're not asking that, what's going to end up happening to you one time is that you think that you got a normal kid who's 3 or 4 years old, and you put him to sleep and everything goes fine, the person's in recovery room, and then you're about to send him home, and all of a sudden the nurses call you back and say, hey, this kid's apneic. And when you go back and talk to the parents, you find out that they're premature. They were premature kids. So 3 or 4 years out, they're still not fully developed in their brain. We stay up there for 6 to 8 hours sometimes. How long? For about the age of 6. So you got to be really, really careful with these kids. And I'll do them first thing in the morning and then watch them for the rest of the day. Nurses are usually going nuts by about 2 o'clock in the afternoon. They realize it's 8 hours at that point. The kid's safe. But I've seen people send these kids home and then they die at home. They have sleep apnea at home, which is not what you want to have. And that was really not their fault. People just said no. Now we know. So there's no reason, absolutely no reason that we should not do that properly. If you want to send somebody home like that, they better be a doctor's kid or a nurse's kid, that you have a central apnea monitor on them. Because what will happen is the parents will go home, they're exhausted too. You don't understand how much emotional stress this does to you. When you put somebody to sleep, it's your family member, you love them very much, and you're finished with the end of the day, you feel worse beat up than the kid did. And the first thing you do when you get home is usually fall asleep. That's why I don't really recommend sending these kids home with parents, even though they're really highly responsible parents, because they'll be exhausted. And they'll just nod off for a second. That's all it takes for the kid also to nod off and not breathe again. Then you got a tragedy in your hands. So I'm not a real fan of doing that. So. Some people have argued that different forms of anesthesia will cause less of a problem. Unfortunately, most of the studies show that it doesn't really matter what form of anesthesia you give them. Even if you're just sedating a kid, you're at high risk of developing apnea. So if you give a kid Versed, and that's all they get, let's say for a MAC procedure, those kids can actually go apneic as well as they get in general anesthetic. So you got to be sort of cautious with these kids. We don't know the exact mechanism why that happens. We just do know that it does. Just be really cautious. Abnormal patterns of breathing, causes of persistent hyperventilation are things like metabolic acidosis. Anytime you see somebody breathing fast, think fever, sepsis, anything that causes metabolic acidosis, like poisonings will cause this. Things like exogenous acids, like aspirin intoxication, or endogenous organ failure, like hepatic coma, renal failure, skeletal necrosis. Fibrotic lung diseases can also cause it because you reduce lung compliance so dramatically. Or increases in BMR with high fevers. Okay? The other things where you see persistent hyperventilation is psychogenic, which is central nervous system disorders of the brainstem and pons. And you get some weird patterns like Cheyne-Stokes breathing. This is stuff that I used to see all the time in the ICU, and hopefully you'll never see this in the OR because these are usually not good signs. These are things that you don't really want to see. It's alternating episodes of apnea and hyperpnea. So you'll see the person go, hold their breath, and all of a sudden they go, and they stop. Okay, and then it's like they go up and down like this. It's really not a good thing. It's an instability of ventilatory control, causes tidal volumes to rhythmically increase and decrease. What the brain is not able to do in this situation is that it's not able to sense CO2 appropriately. So it's sensing that its CO2 is actually going down for some reason, and it makes you stop breathing to hold but it waits too long. And then when it senses the CO2 changes, now it's too elevated, so now it tells you to breathe faster. So it puts you into this kind of cycle. If you were flying an airplane, it would be what's called yo-yoing. Okay, I don't know if anybody knows that as a pilot, but that means you're moving the actual elevator up and down too much, and you're causing yourself to basically go up and down too much. It may occur during hypoxia, sleep, high altitude, or even after voluntary hyperventilation. Then you have apneustic breathings, which you have prolonged inspiration and then followed by interruptions of breathing. Okay, that's usually a sign of the pneumotactic center being diseased. Then you have what's called Biot's breathing, also known as ataxic respiration. And this is normal breathing interrupted by sudden apnea. And it can be a variant of Cheyne-Stokes, and it's completely an irregular pattern. You tend to get very shallow and deep breaths occur randomly, and respiratory rate tends to be slow. And maybe decelerate to apnea, often seen with elevated ICP. Something you don't want to see. If you see somebody with Biot's breathing, which I saw that about 3 weeks ago, this lady came in directly out of the ER right to us, and she was basically dying. ICP pressures were sky high. Blood pressure was 160 over 85, and heart rate was 42. That's called Cushing's triad. You don't want to see that. But then breathing pattern was very erratic. She had Biot's breathing. So we had her intubated and A-lined and burr-holed in 15 minutes. And she actually survived. I found out that 2 days later. I went back to check on her. She was actually intact. It was kind of funny. I talked to her, and she says, "Who are you?" I says, "I'm the man who saved your life." But, and not me, but I mean the team that saved your life. I mean, we were all there, but you were completely out. And wait another 10 minutes, it would have been over. So you have to be really fast sometimes and really move along. And just have to be lucky sometimes. Increased breathing with hypocapnia can occur. These are things that occurs when irritation or fibers are activated, like an asthma and pulmonary embolus can cause the person to become hypocapnic. Kussmaul's breathing can take place from hyperventilation with hypocapnia caused by acidosis, like in diabetics. Again, these are all kind of odd, strange things. You're not going to see it very often now, I think. Hyperpnea of exercise is something that you see all the time just by watching people. You see a steady state of ventilation is achieved in 4 to 6 minutes after moderate exercise. Ventilation at first increases abruptly, then gradually, then reaches a steady state. And what your basically mechanism here is a whole complex system of cardiovascular mechanoreceptors, temperature receptors, chemoreceptors, mechanoreceptors in the muscle, and receptors monitoring metabolic activity. So what happens if you don't breathe properly? Well, you end up with developing what's called ventilatory failure. Okay, and ventilatory failure is not the same thing as oxygenation failure. Ventilatory failure is an inability basically to remove CO2. And basically this can be done to several reasons. It could be from an increased respiratory workload. It could be from decreased gas exchange, although that's pretty rare. It could be from impaired muscle function. CNS problems where you don't really are able to tell the lungs to breathe faster. Things that will cause persistent hypercapnia, okay, things like sleep apnea, central nervous system problems, metabolic alkalosis, mixed edema, coma will also do this. Primary alveolar hypoventilation, which is called Ondine's curse, which is a typical example of high-dose narcotics. Spinal cord lesions, chest wall diseases, neuromuscular disorders, and COPD can also all end up causing ventilatory failure. Clinical pearls. How is this important? The CO2 response curve is affected by many things, affected by the amnestics that you give, the opiates, the volatiles, and nitrous. But they all work slightly differently on the respiratory drive center. Okay? If you look at the amnestics, they suppress the central nervous system and they affect muscle tone to the upper airway. And as a consequence, that person will lose their airway and be at high risk for aspiration. What you see with amnestics is that you see a decrease in respiratory rate with a very mild decrease in tidal volume. So most people seem to do okay. They get a little bit hypercapnia, but they usually don't get that hypoxemic unless you really are driving the respiratory rate down, really, really down. If you give enough amnestics, which is what we do for when you give Diprovan, you will cause apnea, which of course is not something you want to do very often, unless you're purposely trying to do it. If you look at opiates, opiates work a little bit differently. They work at the respiratory drive center, and they basically, also known as Ondine's curse, they will basically tell the person to stop breathing, or they will breathe deeper but slower. Okay, so they have decrease in respiratory rate, a small increase in tidal volume, but overall minute ventilation is decreased. So that's where they usually catch you on the test question. They'll ask you, say, well, what happens to tidal volume with narcotics? It goes up. Okay, what happens to respiratory rate? It goes down. What happens to minute ventilation? Some people say it doesn't change. No, it always goes down. Narcotics always cause a decrease in minute ventilation, period. So everybody that gets narcotics becomes hypercapnic. Okay? We'll slow. Now, here's where my thing is. You will hear people say very, very stupidly, well, it's not really stupid, it's just that they don't know. Okay, so I guess lack of knowledge would be the better word to be politically correct. They will tell you that they don't believe in giving narcotics at the emergence of a case, because they'll tell you that it slows down emergence, that somehow a narcotic will keep you asleep and you will not wake up. And is that true? Unless you give so much of a narcotic that that person's not breathing at all, and that is true. What people don't understand is, what actually makes me kind of, and it's not really written well in the books, and that's part of the reason, okay? And that's why I'm sort of going off this topic a little bit. When you give narcotics to somebody, what happens in minute ventilation? What did I just tell you? It decreases. Now, when we talk about pharmacology of anesthetic agents next semester with you guys, because I talked to the class before you, we teach you, or I will teach you, that what really makes the person wake up from anesthesia is that they must ventilate off the gas that you put in them. Okay? So if I give you narcotics at the end of the case and I suppress your minute ventilation down, what has happened to my ability to remove the gas out of my body? It's decreased. Now, if I decrease it down to 1 liter per minute, and I give you way too much narcotic, then the person's not going to wake up forever. Okay, but that's not the problem with the narcotic. It's the problem that you gave too much. Okay, instead, you can give just enough narcotic to maintain, let's say, a minute ventilation of 3 liters per minute, and still the gas is going to come out properly. It's a little bit slower, yes, but the person's comfortable. So the answer is, how do you do it? You want to make sure that the person is waking up comfortably, but at the same time, you don't want to suppress the respiratory drive to the point that the person is not able to exhale the narcotics. So that's, and then the reason that, that may seem like what I'm telling you is so easy to understand, but it's not. The reason it's not easy to understand is that because if you'd worked in the OR like I did 20 years ago, you had no monitoring of your anesthetic depth. You had no clue what your volatile anesthetic was doing when you were emerging. You theoretically knew in your mind that the agent was coming off somehow, but you didn't know how. You knew it had to do something with breathing, but you didn't have any way of measuring it. Okay? Nowadays, you guys are very lucky. You have both the inspired and expired concentration of your gases that are coming out. So you can see what's going on. You have actually a measurement number. Okay? And you will notice if you become aware of it and somebody trains you properly, that as the person breathes faster and breathes bigger tidal volumes and their minute ventilation goes up, that the anesthetic concentration falls more rapidly and the person wakes up very, very quickly. And that's what you want. So what happened was in the 80s when we were writing all this stuff up, or people were writing this stuff down, is that they gave narcotics to people and then the people wouldn't wake up, and they said, well, it's the narcotics that's causing it. Not that it was affecting the respiratory drive. And then that person was emerging from the anesthetic. You see how that confusion can occur? Okay. Now the nice thing about opioids is they really don't affect muscle function. Okay? They just affect the respiratory drive center. Okay? So tidal volumes are usually maintained or if not increased slightly. But respiratory drive is definitely affected to the point that minute ventilation is suppressed. Again, opiates work at different receptors. Okay, they work at your mu receptors, okay, versus your other agents like your GABA agonist are going to suppress the central nervous system slightly differently. Again, what am I showing here? Tyrosine hydroxylase. Okay, we went off the deep end. This is where this is where the narcotics work, and now they suppress the actual brainstem and stuff like that. If you look at volatile anesthetics, I'm almost done here, and then we'll start up on the other section, which I find more interesting. I spent the whole weekend working on it. Volatile anesthetics properties is that there are three things. There are actually more than that. There are like four things, but I'll keep it simple. And I will go into this in so much detail next semester or the semester after that when you guys are getting ready to go back to clinical. That'll make more sense. But volatile anesthetics, to keep it simple for now, it has three properties. They're amnestics, they're analgesics, and they're areflexics. Okay? The areflexic actions means that they cause muscle relaxation. Okay, so that means what will happen to the diaphragm's function? Tidal volume will fall, and respiratory rate will do what? Increase. So overall minute ventilation will still do what? Decrease. So everybody that's under anesthesia, volatile anesthetics of any kind, will become hypercapnic. Okay, you may not see it on your end-tidal CO2, but if you draw your blood gas, you'll definitely see it. Okay? The areflexic properties is that they relax muscles by suppressing neuronal activation. They affect all the muscles, even the diaphragm. This reduces your FRC, causes a condition in which the diaphragm doesn't work efficiently. The response is to breathe fast and shallow, and can be partially treated with CPAP or PSP. But most at least, if you look at Halthane, it's very much more potent. Taurine is next, SIBO, and Desperane is the least. If you look at response to sensors in anesthesia, PCO2 response is suppressed. We talked about this before. And then PO2 response is completely abolished, so forget about that as being your sensor at all. You cannot respond to hypoxia by hyperventilating. And blue bloaters will stop breathing on receiving inhalational agents, which is kind of scary. These kind of guys that don't have much reserve, and then you put them on in a volatile anesthetic and they stop breathing on you completely. It can be a little bit daunting. Anesthesia may be very dangerous at high altitudes because of this problem. The oxygen sensors are wiped out in those individuals. And HPV is obtunded and attack you in these individuals. Why do we hyperventilate? And the answer is that we have what's called an amnestic or apneic threshold. Okay? To a certain point, once you hyperventilate to that point, then the person will stop breathing. And you can actually sit there and watch people and not hold their breath after that. Again, just to show you different agents, the diethyl ethers, which had least amount of muscle relaxation, okay, they're actually totally ineffective for it. They were the best maintainers of actual minute ventilation in comparison to the volatile anesthetics of today. Diethyl ether was great because you can actually watch people breathe properly under anesthesia. It was very, very adequate. You can still overcome a lot of the problems of volatile anesthetics if you combine them with nitrous oxide. You will take this curve and not be as bad in where you need to be for CO2. Nitrous oxide, because it's very different than volatile anesthetics, has minimal areflexic actions. So supportive ventilation, it increases respiratory rate, yes. It decreases tidal volume, yes, just a little bit, but overall it decreases minute ventilation. but not as bad as all the other agents. So nitrous is one of those things that is really the best one to use if you're going to let somebody spontaneously breathe. It's basically the least respiratory depression in comparison to the use of any volatile anesthetic alone. So what do you do? What happens during maintenance? You can use nitrous combined with volatiles. Then you add your narcotics to basically get your effect that you want. If you give too much narcotics too quickly, what happens to the person's breathing in the case? It stops. But there's some situations like, let's say you're doing a case and the person's breathing on the ventilator and you don't want that. It's irritating. Well, one way you can do it is just increase your volatile anesthetic, but then you get into cardiovascular depression and all sorts of bad side effects. Instead, you can give that person a narcotic. You can give them a little narcotic to suppress their brainstem a little bit, and all of a sudden then their breathing stops. So there's several ways of getting people to stop breathing. One is to hyperventilate them. Two is to deepen your anesthetic, volatile anesthetic. Third is to add more narcotic. A lot of us will use which one that we want in a certain situation we're in. Okay? Surgical pain by far will stimulate you to breathe. Okay, you put an incision on you, that would tend to wake you up. Okay? So one of the things you've got to be aware of, and one of the things that I know is that surgical pain does do that. So what I do is I usually get somebody spontaneously breathing. Let's say I'm using an LMA, and the person is in. I'll bump them with enough narcotic to breathe them around 8 to 12 breaths per minute. And you'll go like, well, that's really kind of suppressing them pretty hard. And I said, no, wait till you cut the patient. As soon as you cut the incision, then the respiratory rate goes up to 16 or 18, and you're fine. If you don't do it that way, then what the person will do is they'll buck and cough on you as soon as the surgeon makes the incision. So you got to sort of pay up front, get them comfortable, so then when they get the incision, they're not jumping off the bed. Okay? And what should the end-tidal CO2 be if the person is spontaneously breathing? Basically, it doesn't matter. If you're letting somebody spontaneously breathe, the CO2 is going to be in the high 40s to low 50s. That's surgical depth. Okay? You have to accept that. If you're unwilling to accept that in a patient, then you should not let them spontaneously breathe. Okay? Otherwise, if you can't accept it, then it's fine. And I actually did for about the first 3 years of my career, about 75% of the ORs did not have ventilators. So most of our cases were done without any ventilators. We had to let people spontaneously breathe all the time, and they did fine. Okay? If you trained after 1995, almost all ORs in the United States converted to have ventilators. So supposedly after that, and you can see it, the new guys that are coming out, they don't let people spontaneously breathe. They think it's evil. They think it won't work. And I'm telling you, it does work. It worked for 150 years, 100 years, while 1864 is when we started using it, to around 1900. So 100 years, 110 years. It worked fine. Okay? And it still will work now. Except you just have to understand that it's going to pay the price of elevated CO2 levels. Respiratory patterns and emergencies, we use a combined, which is called a balanced approach usually. And when you're doing emergence, you're dealing with volatile anesthetics. We shut them off first. And again, I'll talk to you about this again in pharmacology in more detail. And spontaneous breathing versus mechanical ventilation, there's really two camps. Some people like letting people spontaneously breathe at the end of the case, and other people like using mechanical ventilation all the way to the end. I'm a personal believer in letting people breathe. Yeah, I'm not a real big proponent of mechanical ventilation all the time. The reason I like spontaneous breathing at the end of the case is I can titrate the narcotics before they really are awake, and I'm having them comfortable. When I pull the breathing tube out, the person usually are looking at me like, okay, I'm awake and I'm comfortable, and I really don't care that you still got the tube in my mouth. Versus the mechanical ventilator, people have a hard time gauging their depth. They don't gauge how much pain medication the patient may be on, and sometimes they'll pull the tube out too early, and the person will be screaming, or the person will have a situation where they'll laryngospasm or bronchospasm because of the pain. So you got to be a little bit careful. It works because I've seen guys do it all the time, but just a preferred technique. Now, spontaneous breathing does not mean it'll work every time. If you have somebody who has got a central nervous system lesion, you cannot afford to have that person hypercapnic. If you have a person who is COPD or with bad CO2 retention, no, it's not appropriate to hold CO2 in that individual. So there's situations where I know where I don't use spontaneous breathing at the end of the case. I convert them, I keep them on mechanical ventilation to the last second and then pull the tube out. But it's really not my preferred way. Okay? And then desaturation is something you really do not want to see, and pain can be a very important stimulation to breathing. And we'll stop here for this section. I'm going to go grab a cup of coffee for about 10 minutes. I'll be right back, and then we'll start on the next section, which is ventilators. If you want to... What's that? No, just listen. If you want to stay, it's, like I said, totally elective.